Thank you, Dr. Nishant, for the introduction. Uh, I hope my slides are visible.
Yeah, visible.
Okay, so that was an excellent deliberation, motivating patients by example. So I take the tempo further and I try to explain why is it so difficult to achieve weight loss. And as a corollary to that, I'll be discussing what is metabolic set point, what is the metabolic set point theory, and what are its clinical implications. Now, why is fat mass regulated? I mean, why do we need to have a fat mass? Well, obviously, we all know that so much of weight loss leads to hypothalamic amenorrhea, leads to hypothalamic, I mean, hypogonadotropic hypogonadism. So for reproduction, we need to have a fat mass. Then, obviously, not now, but evolutionarily, when some environmental disaster occurs and we are not able to have food for a long time, that is obviously not important now, but that is how we have developed. So environmental disasters, to cope up with them, we need to have a fat mass. Then we need to cut short our fat mass, once again, not important now, so as to evade predators so that we can run fast. But as we have evolved, the defense against loss of fat mass is much more robust than defense against gain. So that is why we are talking all this about obesity. This is one study published way back, and there are I guess at least 100 more which tell us that there is a definite recidivism to obesity. Here we see that once, either with a very low calorie diet, with or without behavioral therapy, once weight loss is achieved, there is, I mean, relatively slower weight gain, but weight gain does occur. And finally, it ends us bringing back to where we started from. So there is a definite recidivism to obesity, and weight loss, however, in however way it is achieved, obviously not if by bariatric surgery, it does come back. Weight does come back. And why does it happen? I mean, there are two individual mechanisms behind this. One, as weight loss is achieved, the metabolic rate goes down. The resting energy expenditure and non-resting energy expenditure, they go down as more weight is lost. At the same time, we feel more hungry. With weight loss, the satiety signals are not that strong from the hypothalamus. So for the same amount of consumed food, if somebody has lost weight, we don't feel full. And we don't have a perception of how much we have eaten that much. So together with less of energy expenditure and less of full perception, that is what is the perfect storm for weight regain after the motivation for continuing with the diet or behavioral therapy subsides, and hence weight gain occurs once again. So what is the physiology of weight reduced state that pushes us into weight gain once again? So as we discussed, energy expenditure goes down. The basal metabolic rate goes down to the tune of 300 to 400 kilocalorie per day, less than predicted. At the same time, we feel delayed satiation. We feel less full and we end up consuming more food. There is more feeling of reward of consuming food. So there is more motivation of consuming food. There is less of sympathetic nervous system activity. There is conversion of T3 to RT3, so which is once again responsible for the reduction in basal metabolic rate. There is less of leptin because the adipose tissue goes down. So leptin actually is the messenger from the peripheral adipose tissue to the CNS, which tells the CNS that yes, there is sufficient stores in the body, so you should stop consuming more food. So leptin goes down with weight loss. At the same time, the efficacy of muscle contraction is enhanced. So all these contribute to regain weight once a weight loss has been incurred by behavioral therapy or whatever way. So there comes the theory of the set point. All of us have a set point, which is defined as a range of body weight, whereby we are programmed to function at our best. Now, this theory believes that a person's body weight will fight to maintain this particular weight range. If we are overfed, we feel less hungry and metabolism increases, so we tend to bring down the weight. If we are underfed, hunger increases and metabolism decreases, so once again the weight increases towards the set point. We can think of it as a thermostat in a room. For example, if it is set at 70 degrees, when temperature goes beyond 70 degrees, the thermostat turns on the AC and tries to bring down the temperature. When it goes less than 70 degrees, the thermostat turns on the heater and tries to elevate the temperature. So it tries to bring back the temperature wherever the set point was. Now, the physiology of weight control and obesity, or rather the pathophysiology of obesity, is complex. There are multiple levels of control. In a nutshell, we have signals originating from the periphery, both from the gut, from the adipose tissue, from the pancreas, which convey messages to the CNS, particularly the hypothalamus. Hypothalamus in turn regulates the body's metabolism and other various endocrine organs, and hence brings about changes that finally end up in either us gaining weight or reducing weight. So that is in nutshell. One of the important hormones that the adipose tissue produces, which regulates the hypothalamic axis as well, is leptin. Leptin is actually a perception of the CNS that we have ample adipose tissue reserve. So leptin is actually a hormone that tells us, that conveys message to the hypothalamus that there are adipose tissue reserves, and hence regulates the hypothalamic functioning and hence the downstream effector signals. Then one would question, if there is a set point, then why would obesity develop in the first place? I mean, it is obvious that obesity would develop when there is no autocorrection in the usual fashion. So it happens in two situations, and that is what is the concept of classifying obesity based upon set point theory. One is metabolic obesity, where the original normal set point is no longer defended by the homeostatic forces, and the set point rather is raised to the higher level. So body now defends a higher body weight. The other variety is hedonic obesity. Hedonic means pleasure. So here the reward system of food consumption is defective. So here the set point is not altered, rather there is more consumption of food and hence obesity develops. Another pictorial representation of what we are discussing. Suppose this is the body weight set point. When there is weight gain, when there is body increases its energy expenditure and decreases its food intake and tries to defend it. When there is weight loss, once again the reverse changes happen and the body weight is defended. However, suppose this set point changes to a new normal set point now at a higher level. So body would be defending a higher weight now, and that is what is metabolic obesity. And suppose there are changes in the reward system and hence overeating occurs. So once again, despite being the set point being the same, despite being that, weight gain occurs, and that is what is hedonic obesity. So if we plot a graph between energy expenditure on the x and the metabolic mass on the y-axis, if we see that when someone has metabolic obesity, the slope is maintained. Only the set point is higher. Whereas hedonic obesity is actually an outlier of the predicted resting energy expenditure versus the metabolic mass. So this is the concept of metabolic versus hedonic obesity. So sustained overeating leads to a non-set point weight in hedonic obesity. The adaptive increases in energy and expenditure are elicited, but are too weak to overcome the sustained hedonic overeating. That's because of the defective reward system. Whereas in metabolic obesity, the set point itself is higher, which is why obesity occurs. Now, briefly about hedonic obesity, how it occurs and what is the, molecular mechanisms. Cognitive and emotional brain actually guide food intake based upon the reward value of food. Non-homeostatic with regard to energy balance. Now, brain regions which are responsible for this reward system are cortical limbic structures. There can be implicit liking for food, or there can be implicit wanting for more food. These two lead to hedonic obesity. Implicit liking actually is mediated by mu opioid receptor signaling, as well as the CB1 cannabinoid receptor signaling networks, whereas implicit wanting is encoded by the mesolimbic dopaminergic neurons that project from ventral tegmental area to the nucleus accumbens of the corticolimbic structures. So this is about the molecular mechanisms. And there are two hypotheses for hedonic obesity. The first is the gluttony hypothesis, where it is posited that a positive correlation between the amount of dopaminergic signaling in an individual and the pleasure derived from sensory experience of ingestion occurs, whereas the reward deficiency hypothesis suggests that a deficiency of dopaminergic signaling is the cause of overindulgence of food. So the primary characteristic of the hedonic system with regard to the onset and maintenance of obesity is its ability to override the energy homeostatic signals, which is why, despite being the set point the same, obesity occurs. On the other side, metabolic obesity actually has a genetic component as well. 40 to 80% of variance of BMI is attributed to genetic elements only. Mechanisms by which dietary manipulations and weight gain lead to higher defended set point are actually not fully understood, but there is some evidence that leptin resistance plays a part. I mean, once someone keeps on overeating, there is leptin resistance, and that leads to resetting of the set point, which is now defended, and hence, despite efforts, weight loss is difficult to achieve. Now, what causes leptin resistance? There are, explanations for that as well. Chronic exposures to calorie-dense foods, particularly high in fat and sugar, lead directly to cellular leptin resistance in the hypothalamic neurons via these mechanisms, and indirectly, leptin resistance may be caused by diet-induced reactive glycolysis associated with the loss of synaptic connectivity of the hypothalamic neurons, POMC and CART neurons. So there may be diet-induced acceleration of aging of the hypothalamic neurons, and hence the new set point. And this is done particularly by foods which are high in fat and sugar when they are consumed over a long period of time. When calorie-dense foods are consumed over a long period of time, there are changes, both direct and indirect, at the level of hypothalamic neurons, which lead to resetting of the set point. And all of these are responsible for ultimately weight gain. Now, just a summary of what we have discussed so far. Metabolic obesity, we know, is because of elevated body set point, whereas hedonic is because of persistent hedonic overeating. The chief diagnostic distinction for metabolic is lack of adaptive changes. There is no increase in energy expenditure or body mass. Energy expenditure and body mass ratio. And for hedonic obesity, there is increased energy expenditure. So body is trying to defend it, but the defective reward system is not letting it defend the original set point. Psychiatric comorbidity often is associated with hedonic obesity, like eating disorders or depression or anxiety disorders, all these. And treatment we'll discuss in the coming slides. Now, what are the clinical considerations of this classification system in treating obesity? We have to, as far as possible, make a distinction between these two types of obesities. I mean, hedonic versus metabolic. Behavioral and lifestyle modification would primarily work more for hedonic, because their patient is overeating impulsively. Whereas for metabolic causes, we may have to, accrue to pharmacological and other forms of intervention, because they are already the set point is defective. Bariatric surgery can work for both of these obesity types of obesity. And how does bariatric
Dr. Ashish, one more minute.
Yeah, okay. So treatment strategies, I'll just skip this slide. We have discussed this. We have evidence from previous DPP and look ahead trials that unless the body set point is lowered, any volitional weight loss would be temporary. So that is what we are discussing, because there are non-responders to volitional treatment as well. Now, as far as the role of drugs is concerned, there are few medications and whose mechanisms are as yet not very clear. I think I should skip these mechanisms here. Yeah. So what about bariatric surgery, also termed metabolic surgery? Now, what it does is it actually lowers the body's set point. For example, if a set point initially was this, the set point is lowered, and hence body is now defending a lower set point, a lower body weight, and hence weight loss occurs. So this way of treating obesity works for both the types of obesity. And as far as treatment of metabolic obesity is concerned, do we have some drug that works? Well, as of now, it's not very clear. we have evidence from studies from animals actually that the lost synaptic connectivity of ARC neurons of the hypothalamus, if targeted, may be, a possible mechanism of developing new drugs for treatment of metabolic obesity. But as of now, human studies are not there for this. As far as hedonic obesity is concerned, behavioral therapy, as discussed in the previous lecture as well, works well for hedonic obesity. Goal setting, stimulus control, alternative behaviors, cognitive restructuring, all these, and obviously the treatment of primary psychiatric disorder when found. So this way we can manage hedonic obesity better. So finally, to conclude, obesity is a heterogeneous disorder and there is no one size fits all treatment approach. Body weight normally oscillates around a set point, and we can say that the tug of war is going on between homeostatic and non-homeostatic forces. For metabolic obesity, there is resetting of the set point. For hedonic obesity, there is impairment of the reward system. And successful treatment, obesity relies on our ability to better stratify our patients and give fitting treatment. Well, thank you from my side. I suppose I have not overshot my time.